Hello. Hello, everybody. I am Melissa Teply. I go by Mel. I'm the Fellowship Program Director at UNMC. And I am talking about some tips and pearls, some considerations to think about when you are seeing a person for a palliative care consult or in clinic who has a cancer diagnosis. In full disclosure, I am married to a medical oncologist, so that has been very helpful to get a little bit of an insider cue into the brain of the oncologist. So I have 9 pearls in terms of prognostication and symptom management. And then I'll talk about some things that have been very helpful to me in my 7 years of outpatient palliative care that I hope you'll take into consideration about incorporating into your practice. All right, so pearl number 1 is steroids are the best and the worst. Make sure that you're checking with oncology for prescribing steroids if that person is still receiving cancer-directed treatments. So if it's very clear everyone's on board that the plan is no more cancer treatment and it's hospice and comfort measures, you can do whatever you want with the steroids. If a person is on immunotherapy, there's some evidence going back and forth that higher dose steroids might impact the efficacy of the immunotherapy. And then we know all the stuff about chronic steroids in terms of the side effects that the list goes on and on and on. So you can use them with discretion, make sure that the oncologist is aware and on board if you're using higher doses for longer than a few days. Aneta last week talked about nausea. Olanzapine is maybe my favorite medication to use in the palliative care world. I really think about it as like a twofer and sometimes a threefer that I can get away with. It can certainly help with a great deal of the nausea that I see in clinic. It's not 100% guaranteed, but it works pretty darn well. It can make people a little sleepy, and so that can be a nice thing to try to help them fall asleep better. And then I've had one person that I retrospectively diagnosed with bipolar disorder because their mood was much better with having an atypical antipsychotic on board. I also tend to think about olanzapine as a longer acting nausea medicine. So if I have someone who's scheduling their Zofran on a longer term basis, I might consider just switching them to olanzapine to see if they can have fewer pills per day that they're taking. And then you know the side effects with these medicines. You're always balancing the benefits or trying to use the side effects to your advantage. One more thing about olanzapine. The data keeps going back and forth on if it helps with appetite, if it helps with meaningful weight gain. So that's another thing that you can consider. I have not had that anecdotally happen a lot in practice. Alcohol wipes, Aneta also mentioned last week. What I find these to be particularly helpful for is I've walked into the room sometimes and that person has that emesis bag. And I am saying, oh crap, I think I need to send this person down to the infusion center or to the emergency room. And so alcohol wipes can sometimes save me that I can still get through that clinic visit and the person can tolerate it with their nausea being helped. So I have a reference to the randomized control trial that kind of put this idea on the map. This can also be a nice trust builder with patients that I'm not always trying to push pills, that I'm trying to think of non-medication related things that can practically be helpful for them as well. Have a really low threshold to think about other pain modalities when someone is coming in with a pain crisis or worsening pain, and specifically, of course, if it's related to the cancer. Radiation oncology, almost all the time, the oncologist is going to be thinking about this, but there's some times where for whatever reason, it just slipped through the cracks. And so that can be a nice place where I really feel like I'm a part of the team, that I'm making sure that we're all coordinating that care together. And radiation works wonders for people. The other thing to think about is an interventional or intrathecal pain pump. I have only had about a dozen people who have gone through the process with this, but man, like that thing is magical for people. Their pain is so much better controlled. The sedation that they have with opioids, just all those side effects, they might still have a little bit of it, but it's way, way less. The hardest part in my mind is trying to get people to go along with the idea of having something implanted in their body and then getting through the process. But if you have a person who, if you have teams that can place these and manage them on an ongoing basis, this is an amazing resource to have. Uh, this one continues to change. So increasingly, we are seeing cancers that have previously been referred to as stage 4 cancers, which we always equated as being incurable, that are now having seeming long-term remission. So these can be tricky for different reasons. So head and neck cancers, the staging of them, a person might have a stage 4 cancer, but it's because they have a lymph node that's in the neck in a certain place. So if a person has a head and neck cancer with mets to bone, liver, or lung, that is now clearly an incurable head and neck cancer. Melanoma, our like glistening example of this is our former president, Jimmy Carter, who is still on hospice, that he went through a combination immunotherapy and had long-term remission from his melanoma that was metastatic to the brain. Lymphomas, that staging is similar to head and neck where it's tricky. Kidney cancers, some bladder cancers, like immunotherapy is just this massive game changer, and people are having like wild long-term remissions with this. Other things to consider in terms of prognosis is that when people have a breast cancer or prostate cancer with only bone mets, people can live quite a while with those cancers. So somewhere along like 4 to even 10 years and sometimes longer for a small tail of people. And then just keep in mind that prognosis keeps shifting. So when I started in outpatient palliative care and oncology, multiple myeloma was something that I helped patients transition to hospice several times a year. And now I hardly see a person with multiple myeloma. CAR T cell therapy has completely changed the game. Prognostication continues to change in oncology, and so you have to partner with your oncology colleagues about trying to make sure that we're communicating accurately and that patients and families are hearing similar information from all of us. This one gets really tricky. These ideas of oligometastatic disease, mixed response, and pseudo progression. So the example that I'll give you is a patient comes into the hospital and they've got some symptom that is new or worsening. And so we get scans and the scan shows there's a new met that is on the adrenal gland, but the rest of the cancer looks stable. So that's an example of oligometastatic disease. In those cases, most of the time, the oncologist will not call that cancer progression. They will say that this is one spot that grew. And so oftentimes they will send that person for radiation of just that one spot and otherwise continue the rest of their cancer-directed therapy. That's an example of oligometastatic disease. Another thing that might happen, I'm going to skip over to pseudoprogression, is that someone comes in with some worsening symptom and they just started on immunotherapy, let's say 4 weeks ago. And then the scan shows that they've got this like huge change in the primary site of the cancer and surrounding areas. So once again, the oncologist may or may not call that actual cancer progression. So immunotherapy can have this effect called pseudoprogression, where the way that immunotherapy works is that it induces inflammation and irritation around that cancer. And then that is what ultimately causes the cancer to shrink and sometimes at that spot disappear. So pseudoprogression is something where things can look worse on the scans before it gets better. So for that person that's in the hospital, the oncologist is going to be wondering, is this actual progression? Is this pseudo progression? Or is this a complication of the immunotherapy where they need to start high dose steroids? So my plea to you all is just like, I would always get really anxious and like, oh, we have to tell the patient that the cancer is worse. And so I always have to wait on the oncology input before I go talk to a patient. Something that I have also found really confusing is this idea of mixed response. And you will see different oncologists do very different things. So sometimes when there's mixed response, an oncologist will say, oh, this is the start of cancer progression that we're seeing, so we have to be really aggressive and switch cancer treatments. I would say as things get later in the course of a disease and a scan shows a mixed response, and the oncologist, they've told me several times in these scenarios, they're like, I really don't have anything else left. And so we're just going to try to squeeze every last drop that we can out of whatever benefit we're getting from this cancer treatment, as long as the patient is otherwise tolerating this okay. So even with a mixed response, that does not exactly equate to progression. My bottom line on all of this is that as you get out into practice, if you're specifically in oncology settings, it is a huge benefit to yourself and to your oncology colleagues if you start to get an idea of these effects that you can see on imaging, and then what each oncologist individually is going to be recommending to their patients and families. We talk a lot about prognostication, and we bash each other about how everybody's bad at prognostication. My view on this is prognostication is hard, and I'm cynical. I don't think we're going to get better, but we always do the best that we can. In the setting of cancer, those functional status scales are still going to be overall our best predictors for prognostication. So the ones that the oncologist will use is the ECOG scale or the Karnofsky performance scale. So you can read the descriptions on there. For a person to do a clinical trial, generally speaking, they have to be an ECOG of 0 to 1. For a person who is seeing an oncologist in practice, most of them will have a threshold of prescribing cancer treatments as long as the ECOG is 2, 1, or 0. So I would say that it hopefully is exceedingly rare that an oncologist is prescribing cancer-directed therapy when a person has an ECOG of 3 or 4. And there was some debate when immunotherapy came out about like people having a Lazarus effect, and like increasing studies are starting to show that like even with immunotherapy, the people who get the greatest benefit from it have that ECOG of 2 or less. That said, there's always nuances in the work that we do. And so you may see a person who has extensive stage small cell lung cancer, and they're in the hospital and they are sicker than sick. And I'm freaking out that we are not giving them the most transparent information we can. And the oncologist is going to say, hold up, wait, we're going to give this chemotherapy a try. Because generally speaking, in the setting of small cell cancer, that chemotherapy melts the cancer away. And then the cancer will eventually come back, although it's been getting better with immunotherapy after initial chemo. But there can be really dramatic responses for people who look like they're on their deathbed. Same thing with leukemia, lymphoma, same thing with these targeted mutations. I can't tell you how many oncologists I've had, or how many conversations I've had with oncologists where I'm like, they look like they're dying. Like, I think they need hospice. And they're like, wait, just hold on and give me a few weeks. And the people do actually get quite a bit better for some period of time. Again, bottom line here is we have to partner with our oncology colleagues to try to provide the best care possible to patients. I am not watching the chat just in case. I'm going to ask if there's like a super urgent question for people to just unmute and stop me. But I'll real quick, the alcohol wipes, you just have the person smell it for a few seconds, and that effect will last for a few minutes.
Mel, I will interrupt if
Thank you.
something big in the chat.
Perfect.
If you're
Love it.
not sure if you wanna, if it rises to the level of should I unmute and say
Yeah.
something, just put it in the chat. I'm watching it, and so is Jason.
Perfect. I saw it at 7 and I was like, I don't know if they have questions. All right. Another piece to this is what I don't know. I'm starting to feel old now because I trained in fellowship 7 years ago, and I didn't get a ton of this training in my fellowship, and so I've injected a lot of it into our program. Recognizing and validating grief along the course of the illness goes a huge way towards building trust with patients and families that becomes important down the road. And then also with helping them build this idea of prognostic awareness, that ability to tolerate the reality of what's going on and to make plans for like what I see as the right care at the right time for people. And these are teeny tiny threads that you're going to see as you're meeting with patients and families. And there's multiple opportunities that we have to discuss these things, but it's trying to figure out when they kind of bubble to the surface when the patient's ready to talk about it. So as you're going through this year, you're going to see all these overt emotions coming up. You know, we can tell the spouse who's the caregiver that's highly anxious. We can tell when people are in complete shock and they just can't have a conversation. Like, I can't even tell you how many people I've had with their arms crossed, like staring lasers through my head, that they're just so mad at the situation. But I think a lot of these other things can bubble under the surface. And when we start to pay attention to those and uncover those, I think those are some of the most meaningful conversations that we can have in terms of our professional satisfaction, but also for the patient and family in terms of how they're coping and setting more realistic expectations for the future. Um, it was still pretty far into my fellowship when I still just thought that grief was this thing that happened when a person died, and then we grieve and we continue to try to move forward with our lives. But I remember so distinctly the first time I heard this from a patient when they said, it's all the little things that the cancer takes away. And so grief starts probably even before the official diagnosis for people. Once people have a diagnosis of cancer, all of that future that they were looking forward to, that's gone. So there's a number of people that I've met with that they say, I worked so hard all my life. We were looking so forward to our retirement. And then we got this diagnosis 3 months in. So all that uncertainty of the future, gone. As people start to talk with their family and friends about the diagnosis, now those relationships change. So sometimes you get kind of the overfunctioner who's like, trying to like document every daily update on the Caring Bridge and bringing over 47 meals that the person doesn't have room for in the refrigerator. So there's that kind of relationship change. There's also the people that are like so scared of saying the wrong thing that they just kind of stop talking and just kind of stop showing up. And so people already feel isolated and lonely in this experience, and then that can be amplified with how those relationships change. As people start cancer-directed therapies, it's wild. Like, they may be here for 8 hours, then they have to come back in 2 days to get their, like, 5-FU pump off. Like, there is no routine, there's no planning. Like, they don't know how they're gonna feel on Sunday when it's day 5 after chemo if they're only just starting this new treatment. So, like, every day, they don't know what to expect. There's no solid ground to stand on. As people have progression of their symptoms and their disease, they have their loss of health and their loss of normal appearance. And these are all things that like start to get really mixed in with their identity and their view of themselves. I had one person say like they didn't even recognize themselves in the mirror anymore, and just how disorienting that was every morning to wake up to that. And then like the hardest and one of the most like fascinating conversations that I have is when people start talking about that concern of feeling like they're a burden. That loss of function and independence is so huge, especially for our Western culture. And so those are like these burdens that people carry. And it's really hard for them to talk about with their family and friends because those conversations get shut down. Like, oh, don't think about that. Like, we're here to help you. Of course, we love you. But if people aren't able to have some time and space where they can talk through that and witness that, then they're technically not processing through that grief. And so people can get stuck in their grief. So I've seen people who've been on their dying bed that are still processing just like the pure fact that they have this cancer. And we all know it's not exactly a linear thing, but um, and then as people get to the dying process, increasingly they have that grief over the missed out future again. So that fear of missing out, not being with their loved ones the way that they want to be. And so I have it on the side. Like all of these things are to say is life is not normal anymore, and it's not going to get back to where they were. Um, so that can be something that is incredibly meaningful and powerful. And I'll circle back to how that it fits in with communication strategies. This is perhaps the trickiest conversation in my mind is how we are interacting with our oncology colleagues. And this is a direct quote from one of the best oncologists in our cancer center who's like amazing at communication, but also points out nothing is more symptomatic than a progressive cancer. So there are times when, like, the only way we know how bad someone is feeling from a cancer treatment is to stop it and hold it and wait several weeks and maybe even several months. but that doesn't mean that they're going to feel great for the rest of their life. Like the cancer is still going to keep changing. And so it's a really, really tricky conversation when we're talking about the benefits and the side effects and complications in terms of a balance with cancer treatment. And so I think that gets into this kind of us versus them mentality, which I take it as a point of personal pride that I think here at UNMC, like we've gotten a lot better at having more open conversations about this. But these are really touchy, tricky, hard conversations when you're talking with the specialists about the disease that they own. I work in clinic, and so I can like legitimately say that when I'm seeing patients early in their illness course, my hopes are the exact same, like they're in alignment with what that patient and family and that oncologist are hoping for. Like the person's doing okay, they have minimal symptoms. Like I want that person to have as much time as possible, and I am hoping that that time can be as good as possible. Where the rubber hits the road is when the cancer is progressing, things are starting to change, the person's functional status is declining, they're having worsening symptoms. And so now the things that I am hoping for and worried about and prioritizing for the patient as my agenda is going to start drifting and shifting away from what the oncologist may be thinking. So on my end, I start to worry at this point that we might be communicating false hope. So if we're putting a person who's highly symptomatic with like rapid decline on regorafenib for their stage 4 colon cancer, generally speaking, it's not a super great medication. It doesn't really do a ton. And so I worry about like, are we being fully transparent with the patient and family with what to expect with this medication? I also have a much lower threshold for certainty when things aren't going well. So I am like, I have a weird analogy, like in a zombie apocalypse, like I am perfectly fine to be one of the dead bodies that's in the opening credits. Like I do not need to like see how this plays out. So like for a person, hopefully people take that analogy in the right context. For a person who is having this decline, like I want them to have hospice care for as long as possible, as soon as possible to get maximal benefit. But I'm trading that for the uncertainty of what could have been if they try further cancer treatment. On the flip side, I still remember that one of the most recent conversations that I had with an oncologist where they were just staring at the computer in distress about what to do for a patient where it was just not certain if they should continue cancer treatment or if the oncologist should more strongly recommend hospice. And what they'll say to me is, you know, like they're considering this cancer treatment, and the last patient they saw had 8 good months where they were able to like get several trips in. They had wonderful memories that they had with their families. Whereas when we were having that discussion about the next person to try that cancer treatment for, like that person ended up dying a month later. And so you can't predict how someone's going to do with a cancer treatment. And so it's a lot of burden of responsibility that the specialists are holding as they're trying to make these recommendations. And so with that, because they've seen such variability, they need a much higher threshold for their certainty to say, we've exhausted every cancer treatment that we can. This person's dying in spite of our best efforts. It's time for hospice. Anytime I'm working with the specialists, I'm always taking lots of deep breaths if I don't understand what's going on. I take this, I don't know if she originated or not, but Dr. Katie Neuendorf is at Cleveland Clinic, and she said, stay curious, not furious. One of the most important things that has been so impactful for me, especially when I'm dealing with other colleagues in the hospital, is to assume positive intent. No one is waking up in the morning saying that they wish to make Mel Teply have a rage fit in the hospital. Like nobody's doing that. Everybody is waking up each morning trying to do the very best they can for the patients and families and other colleagues that they are working with. And so my question that I'm always asking when I'm confused about what someone else is doing is, tell me how you're thinking through their situation. And I apologize, my lights are turning out. So that's the end to my pearls. What I want to go through next is the framework that I tend to think about in the outpatient oncology palliative setting. That in my mind kind of synthesizes a lot of these frameworks that you're going to be working in over the year that mostly comes out of Vital Talk. And so I have a little bit of audience participation for you all. And so I will try to watch the chat on this. So if you're taking care of someone with an incurable cancer, what are 3 key pieces of information that we share with them over time? Any thoughts in the chat? Yeah. Okay. So there's progression, regression, terminality. We're here to support you. Time prognosis. What I would say is at the start, at the time of diagnosis, that this is an incurable cancer that's going to take your life sooner than expected, than any of us would want. Of course, we have cancer treatments, but like that's the key piece. Like the future looks different from here, but you're not dying tomorrow in most cases. In the middle, we have progression. So things aren't working the way that we hope they would. We're getting fewer and fewer cancer treatment options. And then at some point, we're starting to worry about shortened time. And then when it's late, we have a lot more certainty that we've exhausted all the cancer treatments that we can. This person is at the end of their life, and anything that we try to do going forward is not going to buy them more meaningful time, again, in the way that we wish it could. So this is a helpful framework for me to think through that as I'm talking with the oncologist, like if I try to ask them like, where are we in this? How many more cancer treatment lines? Like, then they'll give me like a 45-minute lecture on their specific cancer and all the nuances of I don't exactly need that information. And so this has become like a little bit more of an efficient way for us to communicate. And this is what I tell my fellows when we're in clinic about like, we're early versus middle versus late. Because in my mind, those are very different conversations with very different agendas, and it has a different urgency to it. And so my dosing of language is going to look different. So I'll give you this first column here that in terms of trying to figure out which conversation we're in, a diagnosis is in the early phase is going to be new, in the middle it's going to be known, and in late it's going to be known with more decline. So in terms of early versus middle versus late, when do we have the highest number of interventions available to fix, reverse, or delay cancer progression? And this is not rocket science. Early, right? So when it's in the early phase, we have lots of options. There's a lot of things we can do. As the person has cancer progressions, we have fewer options, but we still have some stuff. Generally speaking, we're going to get to a place where there's one last thing. Most of the time in oncology, you can identify one last thing. And then when it's late, technically speaking, we are out of intervenable options that are going to work in a meaningful way. And that's a key distinction in my mind. So then the next question is, we have these interventions available. So early versus middle versus late, when do we have the highest certainty that these cancer treatments will be helpful to this person? I've got to vote for middle. Early, right? So we have evidence-based medicine. So we start with the cancer treatment that is going to have the give that person the longest progression-free survival with the fewest side effects and complications, and hopefully helping with their quality of life. Because we talk about this as palliative chemotherapy, right? So it's also meant to help with symptoms from the cancer burden. So then the next question in my mind is, how much can we control? Because this is an important framing device for patients and families. So in terms of being able to control time and symptoms, early versus middle versus late, when do we have the most control? Not rocket science. Early, yay. So this is not meant to be like treating you like preschoolers, but it'll help you remember this a little bit better to go through this in an iterative way. So early, a lot of times the oncologist will say, this is incurable, but treatable. So we can do things to help make this slow down. A key framing device when we get to that late stage is that we really cannot control time as much as we want. What we can control is what that time looks like moving forward. So that's how I figure out which conversation we're in. Then it's like, what are we doing with these conversations? So I already gave you these pieces that when it's early, we're saying at some point, this is going to take your life. When it's in the middle, I hope that this next treatment works as long as possible. And I'm worried that we're now going to the next best thing and the next best thing. Then when it's late, that dosing of language becomes much more firm, much more clear. And I gave you one of my most favorite articles of all time about the I hope and I worry. This is where, I don't know, I may be a cheese stands alone on this, but I really think we need to shift away from thinking about these conversations as goals of care conversations, at the very least in the cancer setting. And hopefully you'll come along with me on this. So, if you think about your most non-medical family member and they like hardly even know what cancer is, and they have been diagnosed with a stage 4 pancreatic cancer, and they're coming in to the cancer center to talk to the multidisciplinary clinic team. What is the thing that your family member is most likely to hope for as their top priority? Cure, right? So at that first visit, we're going to say to them, unfortunately, I have to tell you, this is something that we don't have a cure for. And that person is going to be devastated when they hear that information. They are understandably going to have a lot of strong emotions. And I actually get more worried when I don't see those overt emotions about how things are going to go for that person. But that's a different topic for a different day. That person's going to need some time and space to process that information. And we are hardwired for hope. So that person is then going to come back and they're going to have something that is the next best thing they can hope for. And what's that going to be? Time. Yeah. If you can't cure this, please help me have as much time as possible with this. And so we're going to do that. We're going to do the next thing and the next thing with the cancer treatments. And then at some point along the disease course, the person is going to be nearing their last line of therapy, or we're going to start to see those signs that they're losing weight, they're losing function. It looks like they're in that terminal decline process that is irreversible. And so we're going to say to them, I'm really worried that time is short no matter what we do. And so that person is, again, going to be devastated, and they're going to have lots of big, strong emotions about that. Um, if we are having this conversation early enough where they have time and space to process this, what's the next thing that they're going to hope for? Comfort, right? And so if you're telling me that these things aren't going to buy me more time, why would I keep coming back and spending my precious time here in the hospital or at clinic? Not everyone's going to feel exactly that way, but most people will. And sometimes we're not going to give people, like, just the circumstances being what they are, people aren't going to have enough time to process this information. And then we see this a fair amount of the time in the hospice world. And if you're in the hospital when people are dying, that we might say to them, this is as comfortable as I can get you. And so some people are then going to say, if this is as good as it can be, then I'm ready to go. That of course I love life. Of course, I wish I could be here as long as possible. And I just can't stick around like this. It's too much for my body. And so generally speaking, people will make those shifts over time. But it's our responsibility to tell them like which phase we're in, because if they don't know where they stand, then like sometimes in a way, inadvertently, we're kind of robbing them of that ability to have that grief so that they can try to transition that hope for the next thing. Then the question becomes like, there's what the patient and family are hoping for, but then it's like, what are we actually offering and putting on the table? So I would posit to you all from your residencies that most of the time when you were rounding or that you were going into a patient room, that you probably had a pretty good idea of what your plan was even before you saw the patient. And of course, that's going to tweak and adjust depending on the situation. And so when it is early in the disease process, we have cancer-directed therapies available, and we have evidence-based medicine that tells us that there's a high likelihood that it will help the person live longer and feel better. So generally speaking, early in the illness course, what's our recommendation? Anyone with a brave recommendation? do all the things. Yeah. So we're going to start cancer treatment. And then let's switch over to the late side. In the middle, there's cancer progression. So next cancer treatment, depending on how the patient's doing, that gets a little bit murkier. I'll circle back to that. But when it's late, we don't have any further cancer treatments that are going to work the way that we want them to. And so when it's late, what is our medical recommendation for the patient? Yeah, so when it's late, technically speaking, we don't have other things that are going to be helpful in the way that we want them to in terms of helping them live longer. Like what the patient wants when they're dying is to not be dying. But when it's late, I would say that the next best thing that we can offer is hospice or it is comfort measures only. And so when I'm thinking about those recommendations that like the oncologists are offering, that we're offering out, it's really crucial how we frame what's on the table and also how likely it is to help. So people can disagree with me on this, but I would posit most people will try any intervention that we are offering if they believe it has a clear chance of getting them back to their most recent state of living. So it's not just our responsibility to say, we could try this, we could try that. It's also our responsibility to say, I think it has a low, medium, or high chance of helping you live longer, feel better, or help to maintain your function. And I'm stealing that phraseology from Gretchen Schwarze, who was on a Jerry Powell podcast last year. That was incredible. So our medical recommendation early in the course is do the cancer treatment, then do the next thing. And then late in the course, technically speaking, our recommendation on that late conversation, if you're still with me, is hospice. It's and so this is then my next question is like, what's the point of having a goals of care conversation? So early in the course of treatment, of course, there's going to be a few people who are not going to opt for cancer treatment. And so that's okay. Like we want to screen for that small number of people that if they have a clear, strong preference against cancer treatment, absolutely, I'm not going to force them to do a cancer treatment. And so then we get a couple people each year, stage 4 pancreas cancer, they say thanks, but no thanks. And so then we talk about hospice with them. On the flip side, the late side, if we are trying to have a goals of care conversation here, when we really don't have other things that are going to help as an intervention in the acute care setting, I would argue it is not about what the patient wants. It is not about a goals of care conversation. This is the time when we make a firm recommendation that the next best support we can put into place is hospice. Now, the patient can agree or disagree with that recommendation, and then you can, follow up from there. But really, in my mind, the only place where we have these like shared decision-making conversations is in the middle, where we say, we have this treatment we can try. I don't know how strongly I feel about this, like patient and family, what do you think? And so I want to tie this into like how I have experienced communication in the outpatient setting in our oncology clinic. And this study was really validating to me, that was asking a palliative care team, what did you do when you went into the room to see a patient each time? And how did that change over the course of the illness? And so to put this in a little bit of an easier to view schematic, early in the illness course, of course, we're establishing rapport and building trust. Late in the course, we're talking more explicitly about end of life issues. In the middle, we're trying to address like, where is this person at? What are their expectations? What are they hoping for? And then what I am trying to do along the entire spectrum of that illness is always helping with symptoms, but also helping with coping. And with that coping is really trying to see, can I help you to try to tolerate these strong emotions so that we can talk about the future? And my focus is a little bit less about what do you want and what are you hoping for? And it's a little bit more about, can we focus on the present and how life is and help to talk about the things that you're grieving, and then maybe try to prepare you for the next 1 to 2 steps. So if I'm trying to talk about hospice up here, like it just hits on deaf ears. People are like, I don't understand why this woman is explaining this. So in my mind, everything kind of has a cadence and a tone depending on the timing of where we are in the illness. So I don't mean to assault your eyes with this table, but for me, it's really helpful as I'm talking with my fellows is that I will say this patient's in the early phase. Like there's no urgency. Like we're just going in and making friends versus when we're in the middle, like things are ramping up. If the patient and family are maybe open to it, like this is where we can try to ask permission to talk about some anticipatory guidance for what to expect in the next few months. And then when it's late, then that's really like all we've got as a move is just like making that recommendation for hospice and staying along with the patient and family to support them until hopefully they're ready to accept that recommendation. So I really see the conversations in outpatient palliative care as a sort of ping pong of the communication. I rarely give bad news to patients and families. Most of the time, our oncologists are really clear and upfront with the patients and families about that. And so oftentimes when I'm seeing people, I'm not doing that spikes protocol that we all learn about. What I'm trying to see is where is this patient at? How are they doing? What's their social support like? What are symptoms, of course, but do they have a realistic understanding of where things are? And is that something that I need to try to help adjust over time as I'm building trust with them? When I'm in the middle phase, that oncologist is saying, cancer's worse, here's the next thing. Cancer's worse again, here's the next thing. Most of the oncologists here are pretty good about saying, this is the last thing that I have that will help in the way that I wish it could. And that, in my mind, is a really, really crucial step and a really crucial conversation. And it's something that I have learned to look for when that conversation is happening so that I can make sure that that's when I start to talk about, can we talk about what next steps look like if this cancer treatment doesn't work the way we want it to? Can we talk about hospice as a support going forward? Could we talk about considering a hospice information visit? So that when we get to that late conversation where the oncologist is saying no more cancer treatment, ... And then maybe sometimes they're recommending hospice. Like I have done my job really well, and this has happened a tiny amount of the time. It doesn't happen all the time. But then the patient and family are saying to them, so what do we do next? They might say, okay, so is hospice the next step? Like in my mind, if the patient and family can do that at that visit with that oncologist, like that is where we've got all this alignment of where the oncologist is, where the patient and family are at, and what I can do to help with the communication and realistic expectations going forward. In our clinic, it really varies of like who's putting in that hospice referral, depending on who is the oncologist seeing that patient that day, and I might not be seeing them, versus the oncologist goes in and they have a relatively short conversation with that patient about stopping cancer treatment. And then I go in and I have a more detailed conversation about hospice and making that transition happen. So a caveat to all of this is that I've given you the framework of how I'm thinking about my communication to try to bring up with the patient and family, but also recognizing that there is a wide spectrum of the patients and families that we're seeing in terms of their readiness to have these conversations. I am the queen of conversations blowing up in my face. Like I challenge anyone to tell me like any more traumatizing conversations that they've had. And not that I really mean to like have that competition, um but I think, well, I don't know. I hope you haven't had these, but like you cannot force a conversation on a person when they're not ready to have it. And if you try to do that, as best as I can tell you, it's going to blow up in your face. Because it's blown up in mine plenty of time before I did my fellowship. The key that I have learned along the way is making sure that I'm asking permission before we move any next step forward in the conversation. I have young kids, so this is what my day feels like all the time. It's just like, can I have a private moment? There was a person who was giving a talk once that said, as we're going in these rooms to talk with patients and families, that we're a bowl in a china shop. And so that asking of permission is so helpful. When I hit someone who says no, not when I hit, but when I ask permission and someone says no, they can't talk about it, it's rare. It happens maybe less than 5% of the time. But when that happens, that is so important that I hit on that. And that's such a massive trust builder to identify that they're not ready to talk. And so then like the students that I work with and the learners, they freak out and they're like, but I have to have this conversation. And my question back to them is, how urgent is this conversation today? And so it's either going to be along these three spectra. It's either not urgent, and so that's fine. We can set another time for follow-up. I don't have to push this today. Otherwise, like, it might be a somewhat urgent conversation. Things are changing. I'm starting to get more worried. And so I might try one more time. Like, what would be hard about this conversation for you right now? And I one time I had someone who was like, my car broke down, like I have bed bugs in my house, like this, that, and the other thing. And I was like, I am so glad you told me that. Because if I tried to have this conversation without asking that, then there's no way that that person is actually paying attention to what I'm saying. And then especially if they're not emotionally ready, then I'm losing trust currency with that person. And I'm technically kind of violating their boundaries of what they can talk about in terms of their emotional capacity. Um, if you have to have this conversation, that is okay. Then I have to go back to that person and say, I have to have this conversation today. If it's not with you, then who's it going to be with? Most of the time, people have another person. Sometimes they don't. My experience, if they don't have another person, is that they'll take like a couple moments to collect themselves and then they're ready to have that discussion. And there's like a whole other, like, this has been like the last 4 years of my life of trying to figure out how do we try to prepare people to have these conversations and make it comfortable enough for them to tolerate. This is a lot. Like, again, I don't mean to assault your eyes, but we are doing all of these things subconsciously, intuitively, whatever you want to call it. I call it subconscious cognitive processing. We're constantly trying to read the room about how do we try to discuss reality, but also how do we try to meet people where they're at? How do I try to balance that this person said that they know that they were told that they only have a year to live, but then they want to go see their 3-year-old grandchild grow up and graduate high school, that they're really just hoping they can get to that high school graduation. So how do we hold space for all of these different things, and hold that balance as we're trying to help people kind of inch forward with, again, realistic expectations? Um, uh, I think this is my last slide, and then I'll scroll through for questions. Dr. Carrie Brenner is a psychiatry, she's a background in psychiatry and is a palliative care clinician. My most favorite Jerry Pal podcast of all time is Therapeutic Presence in the Time of COVID. Like, huge plug to go check out that podcast. In it, she says it's about connection, not perfection. I think that sometimes we can get into a little bit of like palliative perfection of like, we need every patient to die with hospice. We need every patient to die on comfort measures. Like, it's a failure if they have died by code in the ICU. And while I agree that those like are things I wish to avoid for people, or I hope that people have hospice as long as possible, if I'm putting that pressure on myself to try to get everyone to have hospice as long as possible, generally speaking, it's not gonna build an authentic connection with that patient and family, because they can feel people are intuitive and they can feel that pressure and agenda. And so if I try to meet that person where they're at and connect with them and what's going on with them, and then try to see if it's possible to nudge them along the way to tolerate the distress of what's going on and to tolerate the reality of what steps are going to be coming next. Oftentimes I'm going to have a much better chance of getting the outcome that I'm hoping for more time with hospice, less time in the hospital at end of life, et cetera. So my cheesy plea to you all is to go out and try to be a connectionist, not a perfectionist. That is the end of my slideshow. I will take a peek at the chat to see there were some questions that were coming in. I'm going backwards. What is the wording that you use to broach urgent conversations without causing panic? Um, uh, my favorite question, my favorite response from patients is how they respond when we first walk in the room, because we always say, "How are you doing?" And most people are like, "Fine," but they're not fine. So you're gonna get all of these little cues from patients and families. And so if they say things are not good right off the bat, then you've already got that priming that they're there with you, that you say, it sounds like things aren't going well, and I'm worried with what I've been hearing. I'm wondering if we can talk about the big picture and next steps moving forward. If they are truly like, life is great, things are okay, but the oncologist saw them and there's like very clear imaging progression on scans. And the oncologist is one who's like, well, cancer's worse, but we're going to try this next thing. So let's forget that the cancer's worse. Then I will just try it like very neutrally. Like, can we talk about that visit with your oncologist? Can we talk about what those most recent scans showed? And then see how they respond to that. And if they're like, sure, then fine. If they're like, well, no, everything just seems to be going okay, and we don't really want to talk about that right now. Um, if their functional status is okay, then I'm probably going to kick the bucket down the road. And especially if they're a family that has been more closed in their communication, they don't want to open up. If they're having functional decline and they're saying that they feel fine and doing okay, then it's really your trust currency. That whatever amount of trust you built, whether it's the first time that you're seeing that patient, in terms of how we sat and listened with them, versus if it's a person that hopefully you've had a little bit more time to build that trust with. I'm gonna dose it depending on how strong I think my relationship is. So I'm trying to think of a person most recently. I just call out the elephant in the room. If it's a person I've seen for a while, I know that you have not wanted to have these bigger discussions. And at the same time, I am seeing things that make me really worried about what's going on. I really feel like we need to start having more of these conversations. How does that sit with you? And if they absolutely say no, then I can set a time for follow-up. I can call them the next day or I can call them the next week. And this is that palliative perfection that, like, let's say they go home and they code and they die at home that night. Like, I was doing the best that I could with where that person was at in their illness course. Again, like, I cannot force that conversation sooner than they're ready. I don't know if hopefully that's an okay answer. Going back, late stage, changing from asking for consent to asking for assent. Here's what I recommend. What do you say about that? Yeah. So seeking assent can lift a large burden from a patient who's gone through so much in their journey. Completely agree with you, Jason. I I worry that we are a little entrenched in the what are the patient's values and goals, and we get so entrenched in that we kind of forget that there's times when like we just really have to be firm in our recommendation and let the patients and families take our recommendation or reject it. Um, Philip asked realistic expectations about clinical trials. People can place so much hope in them. So great question. I have a huge slew of patients that have an ECOG of 0 to 1. They are on last line cancer treatment that the oncologist can think of, and they're looking at clinical trials. And it's almost like I want to create like an image of like that horse race thing at the carnivals where you shoot the water and where's the horse in the progression of things. And my 3 timelines would be what's the body doing over the course of the cancer, what's the information that we've given the patient and family over the course of the cancer, and then where are the patient and family in their coping. Because what's happening with those clinical trial situations is that the cancer is getting worse, but the body is still like doing okay if people are not super symptomatic or having functional decline. And we have been telling, like, we're at the end of the road and what we've been telling them, like, we're saying like hospice is the next step, as they're like, I have a guy, he's working full time right now. And he's on last line cancer treatment and the oncologist doesn't have anything else for him after this. And so in terms of his coping, he's in complete shock and disbelief. And it's like understandable. Like he is working full time and being told that he's going to die in the next 3 to 9 months. And so for those folks, it's the kind of thing where I offer the conversation. If people are not ready to take me up on it, I continue to keep checking in with them. And again, I'm in clinic. That's harder to do when people are inpatient. But as they are willing to open up conversations, when they start to say, like, well, we don't know if we can travel. That's a thread that I can pull. Tell me more about that. Well, I'm really worried about how he's going to do in terms of his energy with trying to get back and forth on this travel. And then I can say, I'm worried about that too. Like there are some things where I just have to try to wait people out a little bit. But still continue to check in with them, that hopefully I'm there to help them, that when the clinical trials are officially off the table, that maybe they're a little bit more willing to take that recommendation for hospice as the next step. Ben, I don't know if I'm keeping up with these questions. I'm going back because I think I missed some.
I missed that. I'm sorry.
I don't know. Am I doing okay on answering these questions?
Yes, you're
Someone
doing
said,
an amazing job of
this is way
answering.
back. Can you share more about imaging findings that look worse on imaging, but are the result of a flare or result of cancer treatment, and how you handle this in discussions about prognosis with patients and families? I've been doing this for 7 years, and so I'm now in a place where I'm gonna call out their names, just like, I know what Kelsey Clutie is gonna say in response to a scan for her GI patients. I know what Nicole Shanka is gonna say in response to a scan for her GBM patients. I know how Aparganti is gonna respond for his lung cancer patients, for the most part. It took me many teeny tiny annoying conversations where I was like, I am so sorry to annoy you, but I'm just trying to learn here. Like, this looks like it's worse, but I want to understand how you're thinking through the situation. Like, I had to go to the oncologist to say, teach me what's going on here, so that, because this is the conversation that would come up. I'm in the room as a palliative care consultant. The patient and the family are saying, what does this mean? And I have 3 options. I can say, go talk to your oncologist about this, which the oncologist may or may not be transparent about it. Or I can say, go talk to your oncologist, which then they may or may not feel like they're empowered enough to do that. Or my other option is to say, I will come back and get the best information that I can share with you. And I've done that enough times that now there's still times when I have to go ask, like, it's not that I know everything, but I've done it enough times that now a fair amount of the time I can say to patients, and they know I'm not an oncologist, I think that this is what this means. I think that this is what the next step is going to be from the oncologist. Again, I want to reiterate that I've been doing this for 7 years in clinic, and it took me 5 years to accumulate that comfort. So for me, it was really uncomfortable, but like, being curious and humble, I think earned a lot of trust with the oncologist, that I wanted to learn from their expertise. Is that everything? I think that's everything.
Awesome lecture, Mel.
Thank you.
Yeah.
Enjoy fellowship. It's an awesome year. It gets kind of scary once you're out as a attending, but you have a huge community, so you have lots of people to rely on.